Good afternoon. Today we'll be covering induced hypothermia after cardiac arrest. The presentation was compiled by Athens CNL students April Childs, Amy Eaton, Melissa Hesenthier, Ivy Howard, Jen Joshi, and Kayla Meek. During the presentation, keep in mind the term hypothermia. Hypo means below, and thermo refers to regulation of temperature. Induced hypothermia is also known as code chill and more recently target temperature management or TTM. Here are the learning objectives that we'll be covering today, including complications associated with induced hypothermia and nursing care of how to take care of patients receiving induced hypothermia after cardiac arrest. Therapeutic hypothermia, or TH. Therapeutic hypothermia, or TH for short, refers to deliberately reducing the core body temperature to a range of 32 to 36 degrees Celsius, in which a patient does not regain consciousness after a return of spontaneous circulation following cardiac arrest, and the study was from the American Nurse Today in 2017. And the purpose of TH is to reduce long-term complications and improve patient outcomes post-cardiac arrest. This is an important intervention because many patients who survive cardiac arrest will later die due to subsequent brain damage caused by lack of oxygen. If a patient goes into cardiac arrest and is resuscitated, the patient may meet the criteria to receive therapeutic hypothermia, which lowers the core body temperature, which therefore slows down the metabolism and limits inflammation, which potentially limits the long-term neurological complications. And this illustration demonstrates the process of the cardiac arrest and what you can do in order to cool the patient down. How therapeutic hypothermia works. There are 3 different methods hospital uses to induce therapeutic hypothermia. The first tool is a transnasal evaporative cooling device. This device is a tube that's inserted into the nasal cavity. It sprays a coolant mist that helps to cool the brain in the bloodstream. Second is a water blanket and cooling cap. The patient is covered with a water blanket and a cooling cap is placed on their head. Cool water is then circulated either through the blanket and/or the cap. You can remember this as a lot of athletes who might exercise in extreme heat will want to have some kind of way to cool them down, and a water blanket or cooling cap would be a viable option. Lastly is the cooling catheter. A cooling catheter is inserted in either the femoral, subclavian, or jugular vein. A cooled saline solution is injected into the bloodstream and circulated to cool the patient to the desired temperature. Once again, the 3 ways therapeutic hypothermia works: transdermal evaporative cooling device, water blankets and cooling caps, and lastly the cooling catheter. There are 3 phases of therapeutic hypothermia: induction, maintenance, and rewarming. Phase 1 is induction. During the induction phase, the goal is to get the patient's body temperature lowered as quickly as possible. There are a number of methods to use to lower the patient's body temperature to target range. These methods were discussed in the previous slide, but just to reinforce, you could use ice packs, ice lavage, rapid cold infusion, non-invasive cooling devices such as a gel pad or wrap, or an intravascular catheter that circulates cold fluid in a closed loop within a large vein. And this study was completed by Deckard and Abbott in 2011. Patients are typically sedated and are given a neuromuscular blockade to prevent shivering. They are also carefully monitored for signs of fluid imbalance, which may lead to hypotension or cardiac dysrhythmias. Secondly is phase 2, which is the maintenance period. A way to think of maintenance is you want to maintain or be able to regulate that target temperature range for up to 24 hours. And then depending on each hospital's protocol, the 24-hour period can begin when the induction is first started or when the patient reaches the targeted temperature range. Lastly is phase 3, which is the rewarming stage. And the rewarming stage is when the patient's temperature is increased 0.15 to half a degree Celsius per hour to prevent electrolyte shifts. Since electrolyte shifts can cause cardiac arrhythmias, it's important that the patient is monitored closely during the rewarming phase. Once again, the 3 phases of TH include induction, maintenance, and rewarming. Induced hypothermia works by reducing the metabolic demands of the body, which reduces oxygen consumption, therefore preventing ischemic reperfusion injury. Oxygen conservation is vital because prior to the use of TH, patients who suffered cardiac arrest would later die due to subsequent brain damage caused by a lack of oxygen. Also, you want to be able to reduce the metabolic demands to free up more glucose for the brain to utilize and protect the brain from damaging effects of hypothermia, which is a common physiological phenomenon in patients post-cardiac arrest. Reduction of core body temperature reduces neuroexcitability, which prevents inflammation of the brain and subsequent neurological damage. In this illustration, you can see that the nurse is with the patient checking all the lines of the therapeutic hypothermia delivery system. You want to make sure that the lines are working and that the pads are still in proper placement. More so, you want to also be vigilant about checking the patient's temperature, that it's being controlled regularly within that range of 32 to 36 degrees Celsius. Potential complications associated with therapeutic hypothermia. There's shivering, seizures, electrolyte imbalance, cardiac dysrhythmias, infection, cardiac electrical storms, and we'll go over that in more detail. So just to piggyback off all those ideas, therapeutic hypothermia can improve survival rates and neurological function, but there's a number of potential complications that can arise with this treatment as well. For instance, one complication is shivering. Shivering increases metabolic demands in the body, which increases ICP, intracranial pressure, and can even double or triple oxygen consumption, leading to hypoxemia or myocardial ischemia, which can be life-threatening to a critical patient. Also, seizures, posturing, electrolyte imbalances may lead to cardiac dysrhythmias, including a prolonged QT complex or even cardiac storms that can lead to ventricular fibrillation. There can be an increased risk of infection, such as pneumonia or sepsis, and reductions in a patient's neuroexcitability can make determining neurological prognosis difficult. Therefore, we want to be able to recognize early signs of health decline, such as PVCs on telemetry, or nonverbal cues of pain. That way the nurse is able to help intervene before more serious complications develop. And by having frequent neurological assessment is recommended, because if the patient has a lack of the pupillary light reflex after therapeutic hypothermia, that is an excellent predictor of a poor neurological prognosis. This slide goes over more detail of the nursing care. Nurses play a very important role in monitoring patients who are undergoing therapeutic hypothermia. Nurses need to make sure that they're checking the patient's core body temperature and that it's being maintained at a specific set temperature. They need to maintain a strict intake and output of all their patients and be hypervigilant in performing a frequent vital sign check to ensure even small, subtle changes are spotted immediately. The nurse has to assess for signs of seizure activity, shivering, which could both be life-threatening to the patient. Additionally, the nurse must ensure that all the medications are administered promptly on time, because you want to be able to provide that neuromuscular blockade and sedation, which helps to prevent the patient from shivering and undue discomfort, which can inadvertently increase metabolic rate and core body temperature. The nurse will also need to assess the patients for signs of potential pain. Those may include restlessness, grimacing, a provoked gag reflex, tachycardia, and the nurse may anticipate providing more analgesics as indicated. Nurses also are responsible to monitor the lab results, paying close attention to any kind of shift within the electrolytes, which could cause cardiac arrhythmias, and then of course monitor the skin integrity, as if the patient's kept immobilized for an extended period of time. Oral care is critical for the prevention of pneumonia because the patient's ventilated and under sedation. The nurse should alert the healthcare provider of any signs of impending complications. The family plays a critical role in the patient's survival rate. So most people are not really familiar with the practice of therapeutic hypothermia. Families who are already trying to cope with the news of their loved ones suffering from a massive heart attack might be frightened or stressed to see their loved one cold to touch, unmoving, they're hooked up to various medical equipment. Therefore, the nurse needs to take the time to really educate the family on the medical intervention, what types of equipment is being used, the purpose behind the equipment, why the patient needs to be sedated, and how the patient's pain is being managed during this procedure. The nurse can also provide care goals and discuss that with the family and explain the timeline with the treatment, such as including the maintenance and rewarming phases of care. Most importantly, education and including the family in providing care for the patient can help loved ones feel more connected to the patient, and their treatment can provide more hope for their recovery. The clinical practice guidelines, there were 2 studies completed from the American Academy of Neurology and the American Heart Association. The AHA and the American Academy of Neurology have both endorsed the therapeutic hypothermia treatment protocol for post-cardiac arrest patients. The American Heart Association has practiced clinical guidelines that recommend initiating targeted temperature management at 32 to 36 degrees Celsius for the 24 hours for non-responsive patients who had a return of spontaneous circulation after cardiac arrest. The American Academy of Neurology's clinical guidelines state that the AAN shares strong evidence that the therapeutic hypothermia is likely to be effective in improving neurological outcome and survival compared to normal thermia, and should be a viable option offered. Here is a picture of the AHA Adult Immediate Post-Cardiac Arrest algorithm, and this algorithm was updated in 2015, and the algorithm provides a great visual to see how targeted temperature management is initiated on a patient. As you can see on this algorithm, targeted temperature management is initiated at step 7. If a patient has had a coronary reperfusion, which means blood flow has been restored to a patient's heart, and they're not able to follow commands. Remember that if a patient does not regain consciousness after the return of spontaneous circulation, Targeted temperature management is a critical step in helping to improve patient outcomes and reduce long-term complications. We are going to present a case to you, and we'd like you to make a post and answer to the 3 questions presented in the discussion board that was identified to you on your instruction sheet. Please also comment on another person's post. Once again, we're going to present a case to you, and we'd like you to answer the questions presented in the discussion board that was discussed on your instruction sheet, and please also comment on one another's thoughts. Here is a list of our references. This was a lot of material, so please do not hesitate to reach out. Let me know if you have any questions. My email is jjoshi@augusta.edu. It's J as in Jerry, JJOSHI@augusta.edu. Thank you for your time.